Welcome to The Explainer. Today, we're setting the stage for a really fascinating deep dive into a highly complex and honestly often misunderstood family of diseases. We're going to explore the world of spondyloarthritis, and we'll be doing it using a highly visual, systems-based approach. You see, we aren't just looking at a single joint here. We're going to uncover how genetics, biomechanics, and our very own immune systems wire together to create a profoundly interconnected inflammatory family.
Okay, let's dive right into this with a question that completely flips our traditional understanding of injury on its head. What kind of back pain actually gets better with exercise but feels significantly worse when you just sit and rest? Think about it. If you pull a muscle, you want to lie down, right? But with inflammatory back pain, which is the absolute hallmark of spondyloarthritis, the exact opposite is true. Rest breeds stiffness and pain, while movement actually brings relief. It's a totally counterintuitive symptom, but it perfectly introduces the unique pathophysiology we're about to decode today.
So, here's our roadmap for The Explainer. First, we'll cover the classification of the SPA family. Second, origins and pathogenesis. Third, clinical signs and symptoms. Fourth, radiographic features and imaging. And finally, we'll wrap up with targeted therapeutic interventions.
All right, let's jump straight into Section 1, Classification of the Spondyloarthritis family, taking a look at the spondyloarthritis spectrum.
To make sense of this spectrum, it really helps to think of it like a giant mental filing cabinet, split into two main sections. On one side, we have axial spondyloarthritis, or AX-SPA, which predominantly targets the central axis of the body. We're talking specifically about the spine and the sacroiliac joints in the pelvis. Now on the flip side, we have peripheral spondyloarthritis. This side focuses its inflammatory attack outward onto the limbs, the digits, and importantly, the antices. For a quick refresher, the antices are the precise points where your tendons and ligaments attach directly to the bone.
Building on that anatomical split, distinct conditions fall neatly under these two clinical umbrellas. Under axial SPA, we have radiographic AX-SPA, which you might historically know as ankylosing spondylitis, along with non-radiographic X-SPA. We'll differentiate between those two a bit later when we get to imaging. Now, under peripheral SPA, we see some incredibly diverse systemic diseases fitting into the picture. We have psoriatic arthritis, which is driven by skin psoriasis, inflammatory bowel disease-associated arthritis, which links Crohn's and ulcerative colitis to joint pain, and reactive arthritis, which is typically triggered by a preceding gastrointestinal or urogenital infection.
Moving on to Section 2, Origins and Pathogenesis. We are now zooming way into the cellular level.
You know, you simply cannot discuss the origins of spondyloarthritis without shining a huge spotlight on the HLA-B27 gene. HLA-B27 is a major histocompatibility complex class 1 allele. Think of it kind of like a very specific genetic ID badge sitting on the surface of your cells. And it is, by far, the strongest genetic risk factor for this disease. To put this into perspective, this allele is present in roughly 5% of the general Caucasian population. But if we look at patients with radiographic axial spondyloarthritis, HLA-B27 is present in a staggering 85 to 90% of them. Its presence massively shifts the odds. But the big, multi-million-dollar scientific question has always been, how exactly does this gene cause the disease?
Well, that brings us to the two leading scientific theories. The first is the arthrogenic peptide theory. Since HLA-B27 is an MHC class 1 molecule, its normal day job is to present peptides to CD8-positive T cells. This theory basically suggests it presents a specific disease-triggering peptide that accidentally sets off a massive adaptive immune attack. The second, increasingly prominent theory is homodimerization. This suggests that HLA-B27 molecules behave abnormally and actually pair up with themselves, forming these weird homodimers on the cell surface. These structures then interact with innate immune receptors, like KIR3DL2, and explicitly trigger the production of IL-17, which, as we know, is a massive driver of inflammation.
Now, what's really interesting about this next concept is how our genetics can literally collide with basic physics. We're looking at biomechanical stress as a gateway to chronic disease. Look, in all of us, everyday physical wear and tear causes tiny microdamage at the anthesis, again, those tendon-to-bone attachment points. Normally, this triggers a quick, self-limiting repair response. No big deal, right? But in patients predisposed to spondyloarthritis, this routine mechanical strain sets off an immune response that is inappropriately enhanced and drastically prolonged. The inflammation goes chronic, ultimately tricking the body into pathological new bone formation.
I always like to think of cytokines as the chemical messengers coordinating the immune system's attack. What you see here is how different disease domains, the gut, the spine, the peripheral joints, and the skin all rely on overlapping yet distinct chemical messengers. Notice how TNF-alpha is a broad, overlapping messenger found across all these tissues. But if you look closer at the spine and the skin, you see a really heavy reliance on IL-17 and IL-23. Understanding these cytokine hubs is absolutely vital because it proves a fundamental point. Inflammation in your gut and inflammation in your spine are speaking very similar, albeit slightly different, chemical languages.
All right, let's step back out to the whole patient. In Section 3, Clinical Signs and Symptoms, the systemic impact.
Because of those overlapping cytokine hubs we just discussed, the symptoms of spondyloarthritis actually pop up across multiple body systems. We already mentioned inflammatory back pain, which ironically improves with exercise. But look at these other key manifestations. We have enthesitis, which frequently presents as severe, agonizing heel pain, kind of like Achilles tendonitis, making that very first morning step absolutely unbearable. Then there's dactylitis, where entire fingers or toes swell up uniformly. This is often colloquially called sausage digits. And we have uveitis, an acute, highly painful unilateral inflammation of the eye that causes extreme sensitivity to light. This clearly illustrates that we are dealing with a disease that affects much, much more than just the spinal joints.
Which leads us perfectly into Section 4, Radiographic Features and Imaging, where we finally start visualizing the structural damage.
And this brilliantly illustrates exactly what we've been talking about. On a standard plane radiograph of the pelvis, we can see the classic presentation of bilateral sacroiliitis. Notice that distinct marginal sclerosis, that dense, unusually white bone outlining the joint, right alongside areas where the bone looks almost chewed away. Those are the erosions. When these changes become visible on an X-ray, we formally classify the patient as having radiographic axial SP. And it's worth noting, alongside this axial damage, peripheral joints can suffer severe destruction too. You might see the classic pencil-in-cup deformity, often found in psoriatic arthritis, where the end of one bone whittles down to a point while the adjacent bone expands around it like a cup.
Now, if the inflammation at those enthesial attachments is left unchecked, we see the terrifying reality of pathological new bone formation. This lateral X-ray of the cervical spine shows advanced disease, and it's pretty stark. You can clearly see bony bridges, called syndesmophytes, forming vertically right along the outer fibers of the spinal discs, literally fusing the vertebrae together. Combined with fused facet joints in the back of the spine, this creates a severe restriction in neck and spine mobility, something that historically has been referred to as a bamboo spine.
But here's a crucial question. What if a patient has all the clinical symptoms, but their plain X-rays look totally normal? Well, that is exactly where MRI changes the game, allowing us to diagnose non-radiographic axial SA. On the left, we have a T1-weighted MRI showing structural bone erosions. But on the right, the stir sequence MRI is the real detective here. That bright white signal you see in the sacroiliac joint isn't bone fusion, it is bone marrow edema. It's active, deep tissue inflammation. Modern imaging like this lets us spot the fire and extinguish it long before the permanent structural damage of a fused spine can ever occur.
And extinguishing that fire is what Section 5 is all about: targeted therapeutic interventions. Let's open up the modern medical toolkit.
Our therapeutic approach here is all about progressive escalation. The first line of defense isn't just taking an Advil when it hurts. It's using continuous, maximum tolerable doses of nonsteroidal anti-inflammatory drugs, or NSAIDs. If the disease remains active despite that, we don't even bother with conventional oral DMARDs for spinal disease because they simply don't work for the spine. Instead, we escalate straight to the heavy hitters, the biologics. We use TNF inhibitors, which show broad efficacy across the disease spectrum. We use IL-17 inhibitors, like secukinumab and ixekizumab. And for patients who fail TNF inhibitors, we can turn to targeted synthetic JAK inhibitors like tofacitinib and upadacitinib.
But choosing the right biologic brings us to a really fascinating nuance in rheumatology, something we can call the cytokine paradox. Remember how we said IL-17 and IL-23 are heavily involved in these diseases? Well, IL-17 blockers are incredibly effective at shutting down inflammation in the spine. However, they are totally contraindicated if a patient has active inflammatory bowel disease. Why? Because IL-17 actually plays a protective role in maintaining the gut barrier. Conversely, IL-23 blockers are fantastic for treating IBD and skin psoriasis, but clinical trials showed they inexplicably failed to treat axial spinal inflammation. This means doctors have to be incredibly careful and highly personalized when treating a patient presenting with both spinal disease and gut issues. It's a massive balancing act.
And this brings us to a pretty profound realization to end on.
We've journeyed all the way from mechanical stress and HLA-B27 homodimers to deep tissue MRIs and cytokine paradoxes. We are clearly no longer just treating general pain. As we continue to decode these incredibly intricate, interconnected cytokine networks across the gut, the skin, and the spine, will the future of chronic pain management lie not in hiding the symptoms with painkillers, but in simply and cleanly unplugging the very specific inflammatory messengers that are causing the fire in the first place? Thank you so much for joining me in this explainer, and keep questioning the science.